Good morning, students. I am Dr. Pujitha, Assistant Professor of Pulmonary Medicine. Today, I am going to discuss about eosinophilic lung diseases. What is pulmonary eosinophilia? Pulmonary eosinophilia is an heterogeneous group of pulmonary disorders characterized by either peripheral blood eosinophilia or tissue eosinophilia. That is pulmonary parenchymal or peripheral blood eosinophilia. It may involve parenchyma or airways. What is normal eosinophil count? What is eosinophil? Eosinophil is a polymorphonuclear leukocyte. A normal absolute eosinophil count is less than 500 per cubic millimeter. If it is the counts is in between 500 to 1500 is mild eosinophilia. The rise of 1500 to 5000 is moderate eosinophilia. If the eosinophil count is more than 5000 per cubic millimeter, then it is severe eosinophilia. And also, we have to investigate BAL eosinophil counts for pulmonary parenchymal eosinophils, any pulmonary pathology. What is BAL? BAL is bronchoalveolar lavage, that is performed through bronchoscopy. Is a diagnostic bronchoscopic procedure. In sometimes it is therapeutic also, but mainly diagnostic bronchoscopic procedure. A bronchoscope is passed either through nasal or oral route. Through this, a sterile distilled water or normal saline is injected through the bronchoscope into the subsegmental airways. Then it is suctioned back. The fluid is sent for analysis, and that eosinophil percentage is assessed. Approximately 300 ml of fluid is injected and suctioned in a phased manner of 2 to 60 ml in divided doses. A total of 300 ml of fluid is injected and then collected, sent for analysis. In that, BAL eosinophil percent is normal is less than 2%. If it is more than 5%, then we denoted as increased BAL eosinophil count. If eosinophil percentage of more than 20%, then it is called as pulmonary eosinophilic syndromes. Then coming to classification of pulmonary eosinophilia. In 1932, Loeffler first identified the association between pulmonary infiltrates and eosinophilia. In 1952, Reeder and Godrich coined the term pulmonary infiltrates and eosinophilia syndrome. In 1952, Crofton classified this as simple pulmonary eosinophilia, prolonged pulmonary eosinophilia, tropical eosinophilia, pulmonary eosinophilia with asthma, and polyarteritis nodosa. But later on, it is reclassified in a simple way into pulmonary eosinophilic syndromes of known cause, pulmonary eosinophilic syndromes of unknown cause, and other lung diseases variably associated with eosinophilia. Coming to pulmonary eosinophilic syndromes of known cause. Known cause means there is underlying etiology. Those are parasitic induced eosinophilic pneumonias, including Loeffler syndrome, drug or toxin induced eosinophilic pneumonias, tropical pulmonary eosinophilias, allergic bronchopulmonary mycosis. These are known causes. And coming to eosinophilic syndromes of unknown causes. Unknown causes are acute, idiopathic acute eosinophilic pneumonia, chronic eosinophilic pneumonias. All these are idiopathic. Idiopathic means unknown etiology. Acute eosinophilic pneumonia, chronic eosinophilic pneumonia, Chad-Strauss syndrome, and idiopathic hypereosinophilic syndrome, IHS. These are unknown causes. And other lung diseases variably associated with eosinophilia are asthma. In asthmatics, there is a rise in eosinophil counts. Eosinophilia is there. And bronchocentric granulomatosis, bronchiolitis obliterans agonizing pneumonia. Infections like some fungal infections like coccidioidomycosis, aspergillus, and pneumocystis jirovecii infections in some patients with tuberculosis. In some cases of interstitial lung diseases like IPF, idiopathic pulmonary fibrosis, collagen vascular diseases like sarcoidosis, eosinophilic granulomas. All these are associated with rise in eosinophil counts. In some cases of malignancies, non-small cell cancer of lung, non-Hodgkin's lymphoma, myeloblastic leukemia, etc. All these are diseases associated with eosinophilia. And these are classified in a simple way as eosinophilic pneumonias with acute presentations. These are Loeffler syndrome, parasitic infections, drug and toxin-induced pulmonary eosinophilic syndromes, idiopathic acute eosinophilic pneumonia. All these are acute course. Symptoms present within short duration. Coming to Loeffler syndrome, that is simple pulmonary eosinophilia. Simple pulmonary eosinophilia is also known as Loeffler syndrome. Loeffler, 1932, first described this clinical syndrome is characterized by mild respiratory symptoms with peripheral blood eosinophilia and infiltrative lesions in lungs. Those are transient and migratory lesions. Mainly clinically mild symptoms. Investigation: hematologically peripheral blood eosinophilia, radiologically transient migratory pulmonary infiltrates. It can affect all age groups. The main cause of Loeffler syndrome is hypersensitivity reaction to Ascaris lumbricoides infection. Is a parasitic infection leading to immune hypersensitivity. Causes pulmonary eosinophilia. My clinical features are mild, low-grade fevers, non-productive cough, dyspnea, and hemoptysis occasionally. All these manifestations are self-limited, and they typically resolve within 1 to 2 weeks. So, how to investigate this Loeffler syndrome? Peripheral blood investigation shows moderate to extreme eosinophilias. Sputum also contains eosinophils. And radiologically, chest X-ray show transient migratory non-segmental interstitial and alveolar infiltrates. PFT, restrictive ventilatory defect. Mainly, these are pulmonary eosinophilias. Peripheral blood eosinophilia, pulmonary lesions, chest X-ray show transient migratory non-segmental interstitial and alveolar infiltrates. These are often peripheral. All pulmonary eosinophilias commonly involve peripherally located infiltrates, most commonly bilateral lesions. These are chest X-rays of some patients with simple pulmonary eosinophilias. It may present as diffuse bronchopneumonia or miliary mottling. It can be present as miliary nodules, bilateral diffuse miliary nodules. So, CT findings of peripheral, patchy, non-segmental distribution, transient, migratory lesions. And coming to drug and toxin-induced pulmonary eosinophilic syndromes. The name itself indicates some of the drugs may cause pulmonary eosinophilia. So the onset may be acute or subacute. The respiratory symptoms varied from mild to severe fulminant respiratory failure. Mild respiratory symptoms to severe respiratory failure. The radiographic findings are non-specific. Interstitial or alveolar infiltrates are typical. CT shows bilateral lesions, bilateral consolidation or ground glass opacities. And these are peripherally located most commonly. All pulmonary eosinophilias, the lesions are mainly peripherally located, bilateral involvement. In this consolidation or ground glass opacities associated with concomitant rash and pleural effusion in some patients. The prognosis is favorable in drug or toxin induced because the elimination of exposure to drug leads to resolution of symptoms. So, prognosis is favorable. generally self-limiting after elimination of exposure. And corticosteroids are not frequently used. It can be used in some patients with severe respiratory failure. These are the common drugs that can cause pulmonary eosinophilias. These are acetaminophen. What is acetaminophen? It's a paracetamol. What is acetyl salicylic acid? Is an aspirin. These drugs may cause pulmonary eosinophilias. Amiodarone, bleomycin, captopril. What captopril? ACE inhibitor. Carbamazepine, L-tryptophan, methotrexate, minocycline, nitrofurantoin, penicillamine, phenytoin, propylthiouracil, gold salts. All these can cause sulfur-containing compounds. Also cause pulmonary eosinophilia. So we have to ask thorough history from the patient. Then coming to idiopathic acute eosinophilic pneumonia. This is also an acute presentation. The more commonly affected age group are younger men, approximately 30 years of age. It can occur in healthy persons as well as immunocompromised persons. Immunocompromised means those are with history of chronic myeloid leukemia, HIV infection, recent commencement of smoking, involvement in unusual activities like cave exploration, plant reporting, indoor renovations can occur in healthy persons as well as immunocompromised persons. How to diagnose acute eosinophilic pneumonia? Idiopathic acute eosinophilic pneumonia. Idiopathic means absence of any underlying etiology, absence of infection or a further known causes of eosinophilic lung disease, especially exposure to drug or any other, no underlying known cause. Idiopathic. Acute onset of febrile respiratory manifestation, that is less than 1 month duration before consultation. And eosinophilic pneumonias, eosinophilia, that is bilateral diffuse infiltrates on chest radiograph, bilateral involvement, and hypoxemia, acute presentation. Hypoxemia with PaO2 and room air less than 60 millimeters of mercury, and PaCO2 by PaO2 by FiO2 less than or equal to 300, and oxygen saturation on room air is less than 90%. And lung eosinophilia with more than 25% eosinophils in bowel fluid. These are diagnostic criteria: acute onset of illness, bilateral involvement, hypoxemia with PaO2 less than 60, SpO2 less than 90, PaO2 by FiO2 less than 300, and bowel eosinophil percent of more than 25%, and any other absence of underlying etiology. Coming to what are the clinical features? Clinical features vary from acute illness with the fever, myalgia, cough, dyspnea, pleuritic chest pain, hypoxemia. And patients often may have diffuse crackles on auscultation and develop overt respiratory failure requiring mechanical ventilation. Diffuse crackles heard in patients with impending respiratory failure, ARDS. Presence as ARDS, but shock and extrapulmonary organ failure characteristically absent. Acute onset of illness. Coming to how to investigate, how to diagnose. Acute eosinophilic pneumonia, characteristically, there is no blood eosinophilia. There is no rise of peripheral blood eosinophil count. There is rise in bowel eosinophil counts. This is the striking feature of acute eosinophilic pneumonias. You have to remember these two only: absence of blood eosinophilia, rise of bowel eosinophil counts, that is more than 25 to 50%. Radiologically, there is initially patchy infiltrates with curly B lines early in the course of illness. Later, diffuse involvement, bilateral symmetrical involvement, alveolar and interstitial infiltrates later on going into ARDS with a ground glass or micronodular appearance develop within 48 hours, acute onset with other known underlying etiology. Then we have to diagnose. In that, the diagnostic feature is by Ball eosinophil count, mainly Ball eosinophil count, bilateral infiltrates associated with some small to moderate bilateral pleural effusions. CT confirms the radiological features. This is chest X-ray showing bilateral ground glass appearance. Bilateral opacities with mixed alveolar and interstitial opacities. Most commonly, ARDS picture with minimal pleural effusion not clearly visible, CP angle, curly V lines. These are interstitial edema lines. And CT shows airspace consolidation, peripheral involvement, interlobular septal thickening, ground glass haziness. Pleural effusions are not visible. Coming to the treatment of acute eosinophilic pneumonias. In case of simple pulmonary eosinophilias, resolve on its own. Drug and toxin-induced eosinophilic pneumonias also resolved on exposure, on elimination of exposure to drug. In case of acute eosinophilic pneumonias, we start initial doses of methylprednisolone, typically in the range of 60 to 125 milligrams, administered every 6 hours initially. Every 6th hourly. QID 60 to 125 milligrams of methylprednisolone. And after resolution of respiratory failure, oral prednisolone in a dose of 40 to 60 milligrams per day may be continued for 2 to 4 weeks with a subsequent slow taper over the next several weeks. So, the choice of treatment is steroids, methylprednisolone, in tapered doses. Then coming to chronic eosinophilic pneumonias. Chronic means present for several months. Symptoms present for several months before coming to consultation. Chronic eosinophilic pneumonias, the peak incidence is in between 30 to 40 years. And females are commonly affected than males. And 1/3 to half of the patients having history of allergy or atopy or nasal polyps, and remaining 2/3 having the history of asthma, preceding or concurrent with the occurrence of chronic eosinophilic pneumonias. So that the typical clinical features are this is subacute to chronic presentation. The symptoms present for several months before the diagnosis. So it is chronic without any underlying etiology. Common clinical symptoms are low-grade fevers, night sweats, weight loss, chronic history. So weight loss, night sweats, cough, low-grade fevers. Patient ultimately develop progressive dyspnea, which may be associated with wheezing in those with adult onset asthma. Some 2/3 of the patient having asthma history, so that associated with wheezing also. Less commonly, some patients may develop ARDS with severe hypoxemia. Extrapulmonary manifestations are not commonly occur in chronic eosinophilic pneumonias. So, but rarely arthralgia, skin rash, pericarditis, unexplained heart failure have been described. The classical feature of chronic eosinophilic pneumonia is rise in peripheral blood eosinophilia, that is more than 6 to 90%, almost 66 to 95% of eosinophil counts, rise of eosinophils in peripheral bloods, peripheral blood sample differential counts. But in acute eosinophilic pneumonia, there is no rise of peripheral blood eosinophils, rise of Ball eosinophil counts. In chronic eosinophilic pneumonias, there is rise of peripheral blood eosinophilia. and associated with anemia, thrombocytosis, ESR is also elevated, and there is rise of Ball eosinophil counts also. Peripheral as well as Ball eosinophil counts are also raised in chronic eosinophilic pneumonias for up to 40%. Ig levels are also elevated in 50% of the cases. Blood and sputum cultures routinely fail to identify an underlying infectious etiology. This is also idiopathic. Unknown etiology, what are coming under unknown etiology? Pulmonary eosinophilias without known cause, unknown cause, acute eosinophilic pneumonias, chronic eosinophilic pneumonias, Church-Strauss syndrome, and idiopathic hypereosinophilic syndrome. So all these are unknown etiologies. So we did not find any known cause. And coming to radiographic features of chronic eosinophilic pneumonia. The main classical feature is photographic negative of pulmonary edema appearance in chronic eosinophilic pneumonias, and these are non-migratory infiltrates. Commonly involves peripheral 2/3 and most commonly bilateral, involves in located in the mid to upper lung zones, infiltrates. These are non-migratory, non-segmental or subsegmental or lobar in distribution, opposite to pleura, and may mimic loculated pleural effusion. Mainly, the characteristic appearance is photographic negative of pulmonary edema appearance. Results if extensive infiltrates surround the major portions of entire lung. These infiltrates are typically non-migratory and affect the outer 2/3 of the lung. Mainly, mid and upper lung zones are involved. The rapid resolution of infiltrates occur following the corticosteroid treatment. Acute eosinophilic pneumonias, the mainstay of treatment is corticosteroids. Chronic eosinophilic pneumonias also, the mainstay of treatment is corticosteroids. This is the radiological features. This is involvement of upper and mid zones. This is photographic negative of pulmonary edema appearance. This is the CT of chronic eosinophilic pneumonias, peripheral opacities, ground glass haziness, and septal thickening. How to diagnose chronic eosinophilic pneumonia? Based on clinical, radiographic, and Ball findings, and inability to document any infectious etiology. Mainly, transbronchial biopsy is usually performed to rule out other diagnostic entities. The rapid response is to steroid treatment, so that a therapeutic trial of steroids is often useful in establishing the diagnosis. So we have to give first steroids. If the resolution of symptoms will occur, then we suspect it is as chronic eosinophilic pneumonia in patients with the chronic duration of symptoms, with all those clinical features without any underlying etiology. Failure to document rapid clinical improvement should alert the clinician to consider other diagnosis. What are the differential diagnoses? We suspect it as TB or fungal diseases like cryptococcosis, sarcoidosis, Loeffler syndrome, desquamative interstitial pneumonitis, WHOOP, bronchiolitis obliterans organizing pneumonia, chronic hypersensitivity pneumonitis, and eosinophilic granulomas. What is the treatment of chronic eosinophilic pneumonia? The mainstay of treatment is steroids. We should start with corticosteroids. The recommended dose is prednisolone 40 to 60 milligrams per day until 2 weeks. In acute eosinophilic pneumonia, methylprednisolone 60 to 125 milligrams 6th hourly. In this, 40 to 60 milligrams per day until 2 weeks after the resolution of symptoms and X-ray abnormalities. So we have to continue prednisolone until after the resolution of symptoms for 2 weeks. Then tapered slowly. and the treatment should be maintained for at least 3 months and optimally for 6 to 9 months. Then coming to Church-Strauss syndrome. This is also an unknown etiology. What is Church-Strauss syndrome? It is allergic granulomatosis and meningitis. It is a vasculitis of medium and small vessels. Mainly, it is necrotizing vasculitis. It was 1951, Church and Strauss was described the histopathology and clinical features of Church-Strauss syndrome. They reported a form of Church-Strauss is necrotizing vasculitis. You remember three things mainly. It is necrotizing vasculitis of medium and small vessel involvement, upper airway involvement in the form of sinusitis, mainly involvement of paranasal sinuses, and lower airway involvement, commonly seen in asthmatics. These three things you should remember for Church-Strauss syndrome. In this also we observe eosinophilia. It accounts for 10% of all vasculitis. It is a reported form of necrotizing vasculitis in several organs associated with eosinophilic tissue inflammation and extravascular granulomas occurring in asthmatics. Commonly observed in asthmatics with associated fever and peripheral hypereosinophilia. Necrotizing vasculitis. Church-Strauss syndrome is an uncommon systemic disease. Not common, it's an uncommon systemic disease and typically affects the multiple organ systems. Involvement of multi-organ system is common in Church-Strauss syndrome. It is uncommon in previous pulmonary eosinophilias. Church-Strauss and idiopathic hypereosinophilic syndrome, these two are involvement of multi-organ system is common in these two eosinophilias. It accounts for 10% of all vasculitis, commonly seen in asthmatics. Increased incidence is seen in asthmatics, occur in the age group of 38 to 50 years. No gender predominance, but among the women, the disease onset has been reported during pregnancy, commonly in pregnant women. In case of women, is also subacute course with the symptoms ranging over months to years. The diagnosis of Church-Strauss syndrome includes the American College of Rheumatology tells that Church-Strauss syndrome is commonly associated with asthma, eosinophilia of more than 10%, and neuropathies, pulmonary infiltrates, paranasal sinus abnormality, extravascular eosinophilic infiltration on biopsy. These features are common in Church-Strauss syndrome. Asthma, eosinophilia more than 10%, neuropathies, pulmonary infiltrates, paranasal sinus abnormality, and extravascular eosinophil infiltration. Respiratory manifestations include upper airway involvement, upper airway allergic disease, mainly sinusitis, upper airway, lower airway, major airways, asthma, sinusitis. Rarely, these may land up into bronchiectasis. In some patients, may present as Loeffler-like syndrome. In 38 to 40% of the patients, patients may develop dyspnea, cough, and wheezing. PFT shows obstructive ventilatory defect. What are the in Church-Strauss syndrome there is multi-organ system involvement. Most commonly cardiac system is involved, followed by CNS, renal, and GIT. There is involvement of multiple organs. How to diagnose Church-Strauss syndrome? Church-Strauss syndrome associated peripheral blood eosinophilia, that is rise of eosinophils of approximately 20 to 90%, and rise in IgE levels, that is 500 to 1000 international units, moderate elevation of serum total IgE associated with anemia, and DSR is elevated, peripheral eosinophilia, and special investigations positive P-ANCA in 70 to 75% of the patients. We sent for P-ANCA, anti-nuclear cytoplasmic antibodies, P-type, is positive in Church-Ross syndrome. And if pleural fluid is present, if it is sent for analysis, shows acidotic eosinophilic in exudative with low glucose levels, and pleural biopsy shows eosinophilic infiltration. Bowel fluid also reveals raised eosinophil count. Mainly 70 to 75% of the patients, P-ANCA is positive, peripheral eosinophilias, increased bowel eosinophil counts, IgE levels are elevated, pleural fluid is acidotic. Radiologically shows migratory, transient, non-migratory in chronic eosinophilic pneumonias. That is photographic negative of pulmonary edema appearance. Okay. Radiologically shows transient migratory, non-lobar, non-segmental, often peripheral pulmonary infiltrates. All the pulmonary eosinophilias mainly peripheral involvement. Nodular interstitial involvement is less common. There is pulmonary artery enlargement. Why? Because this is vasculitis, involvement of medium and small vessels. So there is enlargement of pulmonary artery, the irregular stellate configuration of some vessels because of deposition of granulomas, extravascular granulomas. Patchy peribronchial thickening, some areas of septal thickening, scattered patchy parenchymal opacities with ground glass or consolidated appearance. This is transient migratory, appears as loculated pleural effusion, non-segmental peripheral opacities. Peripheral opacities. This is the CT of patients with Church-Ross syndrome, scattered patchy opacities, peripheral ground glass appearance, bilateral minimal pleural effusions, pericardial effusion. Involvement of multi-organ system, so that some patients may develop pericardial effusion. Open lung biopsy is the gold standard for tissue biopsy. Open lung biopsy shows eosinophilic infiltration. Transbronchial biopsy may reveal the diagnosis if there is alveolar involvement, but it's often non-diagnostic. Open lung biopsy is the diagnostic procedure. These are the differential diagnosis of Church-Ross syndrome. Polyarteritis nodosa, microscopic polyangiitis, all these are vasculitis, vaginal granulomatosis, and chronic eosinophilic pneumonias, ABPA, idiopathic hypereosinophilic syndrome, Loeffler syndrome, asthma, fungal or parasitic infection, drug-induced sarcoidosis, Hodgkin's lymphoma. Then coming to treatment of Church-Ross syndrome. Church-Ross syndrome, the treatment of choice is steroids and cytotoxic immunosuppressive agents. These two are the mainstay of treatment, and both can be combined in some patients, those who are not responding to single drug. Prednisolone of 0.5 to 1 milligram per kg per day for 6 to 12 weeks to eliminate the constitutional symptoms. And this may continue up to 1 year. Treatment with cytotoxic immunosuppressive agents also may prove effective. Those are azathioprine, cyclophosphamide, high-dose methylprednisolone, or chlorambucil. And these should be considered in patients whose condition fails to improve with steroid treatment or poor prognostic features, that is multi-organ system involvement, including cardiac or GI involvement, renal, etc. In that, we should combine steroids with cytotoxic immunosuppressive agents. Cyclophosphamide dose of 2 milligram per kg per day, or 0.6 gram per meter square IV per month. may be given concurrently with corticosteroids. In some patients, interferon alpha may be tried. Plasma exchange also may be a successful treatment. Beta blockers should be avoided because of attack of bronchospasm. Beta blockers may cause bronchospasm. It's a side effect. Then coming to idiopathic hypereosinophilic syndrome. Idiopathic hypereosinophilic syndrome. The name itself indicates this is also idiopathic. Hypereosinophilia. Eosinophil counts of more than 1500 per cubic millimeter. The other names of idiopathic hypereosinophilic syndrome are eosinophilic leukemia, low flux fibroblastic endocarditis, or disseminated eosinophilic cardiovascular disease. So that in this also there is involvement of multiple organs. In Church-Strauss and idiopathic hypereosinophilic syndrome, there is multi-organ system involvement. In 1975, Chusid and colleagues revised the definition of idiopathic hypereosinophilic syndrome to include only cases in which no other underlying cause of hypereosinophilia could be found. This is idiopathic. This is also present in between the age group of 20 to 50 years. The clinical features vary from mild form to severe form, involvement of multi-organ system to life-threatening respiratory failures, cardiac failures. The clinical features are non-specific, include weakness, fatigue, weight loss, low-grade fevers, cough, angioedemas, retinal lesions, rash, and dyspnea. Actually, multi-organ system involvement, every organ can be involved. A cough is predominantly mainly nocturnal cough in idiopathic hypereosinophilic syndromes. It's either non-productive or productive. What are the common clinical features of other common features are wheezing and dyspnea are also common without evidence of airflow obstruction or spirometry. In this, there is no limitation of airflow. But wheezing and dyspnea are also common. And pulmonary hypertension, ERDs, pleural effusions have been reported in some cases. In chest X-ray shows focal or diffuse, transient focal or diffuse pulmonary infiltrates with no predilection for any particular distribution. Idiopathic hypereosinophilic syndromes, the common features are low-grade fevers, night sweats, nocturnal cough, rash, angioedemas, retinal lesions. All these are common clinical features associated with wheeze and dyspnea. Involvement of multi-organ system. Cardiovascular involvement in the form of endomyocardial damage or necrosis. Intramural thrombi, endomyocardial fibrosis, congestive heart failure may occur in some patients. Cutaneous lesions like angioedemas, rash, erythematics, purpuric papules and nodules, etc. The neurological features include primary generalized central nervous system dysfunction, neuropathies, pulmonary involvement in the form of fibrosis, cough, non-specific infiltrates, and splenomegaly, hepatomegaly, hepatitis, gastroenteritis, colitis, ocular involvement. All this can occur in idiopathic hypereosinophilic syndrome patients. Most commonly, multi-organ system involvement. How to diagnose idiopathic hypereosinophilic syndrome? Mainly, hypereosinophilia. There is rise of eosinophil counts of more than 1500 per microliter, which persists for more than 6 months. And no identifiable etiology. And patients must have signs and symptoms of multi-organ involvement. There is elevated leukocyte count, that is about 10,000, with predominance of eosinophils up to 70%. This is hypereosinophilic syndrome. What are the features? Eosinophilia of more than 1500, which persists for more than 6 months, no identifiable etiology, multi-organ system involvement, rise of leukocyte count of more than 10,000 with the differential count rise of eosinophils of up to 70%. And also other findings are elevated total IgE, hypergammaglobulinemia, circulating immune complexes, ESR is raised, elevated serum B12 and leukocyte alkaline phosphatase levels, and no other identifiable etiology. These are common differential diagnoses of idiopathic hypereosinophilic syndrome. What are they? Parasitic infections, acute eosinophilic pneumonia, acute eosinophilic leukemias, chest-Ross syndromes, episodic angioedema with eosinophilia, tuberculosis or fungal infection, allergies or autoimmune. All these should be ruled out. What is the treatment of idiopathic hypereosinophilic syndrome? For asymptomatic patients, no need to treat. No need to start any specific treatment for asymptomatic patient. And such patients are closely monitored with serum troponin levels for every 3 to 6 months and echo pulmonary function tests for every 6 to 12 months. And glucocorticoids are the first line therapy in all patients except the patients with F5P1L1 PDGFRA, platelet derived growth factor RA mutation. In those patients with this mutation, we start with imatinib. Imatinib is the drug of choice in the patients with this mutation. This is a 100% success rate in some studies. A high dose of imatinib is the treatment of choice if first and second line drugs fails. Hydroxyurea may be added if there is evidence of further disease progression with the aim of reducing the total leukocyte count to 5,000 to 10,000. Vincristine is also may be used as a chemotherapeutic agent. In extremely high total leukocyte counts, etoposide and chlorambucil are effective alternative for cases refractory to standard treatment with steroids. And cyclosporin may also be of benefit in controlling the disease, especially in combination with steroids. Interferon alpha should be tried as a second line agent among the patients with idiopathic hypereosinophilic syndrome who fail to respond to corticosteroids, and also monoclonal antibodies, anti-IL-5, mepolizumab, anti-CD52, altizumab also may be tried in some patients with eosinophilia. They also show some improvement. They also have shown some improvement. And another eosinophilia is allergic bronchopulmonary aspergillosis. This is a separate entity. This is a full class is required for this ABPA. What is ABPA? Is allergic bronchopulmonary aspergillosis. It is also associated with pulmonary eosinophilias. It is due to, what is the cause of ABPA? It is an hypersensitivity reaction to Aspergillus species, either type 1 or type 3, immediate or immune complex mediated hypersensitivity reaction, type 3, to Aspergillus species, leading to increased eosinophil counts. The criteria for ABPA includes patients with asthma, commonly associated with asthma, nearly 100% of the patients. History of allergy and asthma is there for ABPA patients, and involvement of upper lobes. Central bronchiectasis is commonly seen in ABPA, and fleeting pulmonary opacities. Migrating pulmonary infiltrates also seen in ABPA, and rise in serum IgE of more than 1,000. Rise of serum total IgE markedly elevated in ABPA. And skin prick test is positive for Aspergillus species and rise in peripheral blood eosinophilia. These are classical